Welcome to our final presentation. This is being completed by Evan, Ryan, and myself. So let me tell you a little bit about our patient. He is a 7-year-old male. He weighs 22 kilograms, and his admitting diagnosis is severe pneumonia complicated by pediatric acute respiratory distress, which is also known as PARDS, and septic shock. He's currently in the pediatric intensive care unit, or the PICU. So here's what we're working with. Mateo came in to the ED with his mom. He had already been sick for 3 days prior with a worsening fever, cough, and an increased work of breathing. Mom reports that he'd been treated in an outpatient facility with amoxicillin the previous week for presumed strep pharyngitis, but stopped taking the meds after 2 days because he was feeling better. Over the past 24 hours, he became progressively tachypnic with reduced oral intake, increasing lethargy, and an SpO2 of 86% on room air at home. In the ED, he was febrile 39.2, tachypnic at 46, with a heart rate of 156 and a blood pressure of 82/84. They did do initial chest x-rays that showed diffuse bilateral infiltrates. They did blood cultures to check for, the pneumonia. And he was placed on a high flow nasal cannula, but quickly failed, requiring intubation for the PARDS. So his patient profile or past medical history, he does have mild intermittent asthma, which I'm sure is being exacerbated here. He was premature at 33 weeks, and he stayed for 2 weeks in the NICU. He hasn't had any prior surgeries, and he has no known congenital cardiac diseases. He does live at home with a mom and 2 siblings, and the grandfather lives in the home, and he smokes inside. So he is exposed to secondhand smoke from the grandfather. Mom works 2 jobs, so she's inconsistent with follow-up care. He is up to date on some, but not all vaccinations. Excuse me. And he did miss the flu vaccine this year. So currently he's on IV ceftriaxone and vancomycin for the pneumonia, or the suspected bacterial pneumonia. He's on norepi for the septic shock. He is sedated. He's on Dex and a low-dose fentanyl because he's on the vent. Methylprednisolone due to the severe PRDS, which is a protocol at the facility that he's on this, and then a bronchodilator for asthma, and this is issued PRN. So the current ABG before they had put him on the vent was 731, 52, 64, and 23. And his P to F ratio came out to 91, which is severe PARDS. This is uncompensated respiratory acidosis with hypoxemia. Anything on a P to F below 100 is considered severe. So because he had failed the high flow so quickly, because the P to F ratio was where it was at, he he did qualify for PRDS protocol and being intubated. Also, because he does have mild asthma, this is a key indicator that he could crash pretty quickly, because asthmatics are good until they're not. So overall, we're just taking precautions all the way around and getting him set up right away. Excuse me. Because they did the chest x-ray and they found what they had on there, they had ordered a CT as well to confirm, and they are advancing their imaging strategies and their care strategies for this kid. They did find diffuse alveolar damage, patchy consolidation. Good news is there's no pneumo. And then they did decide to switch over to a lung ultrasound, because this way they can kind of monitor his progress without having to continue to take him back to CT and expose him to the radiation all the time. And what the initial lung ultrasound found was he did have reduced lung exciting and moderate B-line, which indicates that there is fluid buildup in the lung tissue. So he does have some interstitial stuff going on as well. So he failed high flow and is now on the vent setting. He is on PRDS protocol. His initial insult was within 7 days, so that checks the box. He has a low P to F, and his SpO2 was low, and his chest x-rays showed that he had an acute insult. So we did put him onto a vent. So PCSAMV with pressure support. Pressure support, generally we're starting around 10. PIP of 26 and a PEEP of 10. So the PEEP here is higher, part of the PRDS. We want to get those lungs inflated. We want to get that oxygen going. Excuse me. We want to get the oxygenation happening. So we want the PEEP to be a little bit higher to help with that. Then we're going to start our FiO2 at 60% and a rate of 25. So I chose rate of 25 because I am trying to match what the protocol is for his age. And also he does have a high CO2. So I would like to blow off some of this with this rate and also stay within the realm of what he should be breathing at for his age. And then the tidal volume, I have him on a 5 mils per kilogram, which is the lowest PRDS for a peds kid to be on. So technically it would be like 5 to 8, but we should start lower and then titrate PEEP and oxygen as things start to adjust with the ventilator. So we are keeping everything within the parts of the protocol. We want to keep lungs in a safe range to avoid any volume trauma or barotrauma. So we're going to be adjusting pretty often here as his compliance ebbs and flows. Hopefully the compliance becomes greater and we can decrease his PEEP a little bit and his FiO2 because we don't want him up on a high FiO2 for a long time.
We're going to start talking about ventilator-associated vents. So first, what it is, it's just 2 days of decreasing or unstable ventilator settings, specifically in particular dealing with PEEP and FiO2. So I just kind of wanted to go over different prevention strategies and then how it relates to our case study. So different prevention strategies just include minimizing that mechanical ventilation time, and then targeting strategies that target specific conditions, specifically pneumonia, fluid overload, atelectasis, and ARDS. And especially since our case study, his admitting diagnosis was the PRDS, we specifically want to keep an eye out for that. And then also just education on the prevention of ventilator-associated events. Some of the studies I was looking into showed that just education on these actually prevents them a lot more as well. And so for the example over here, I kind of just did a basic textbook example, what it would look like over the course of a couple of days, just these worsening ventilator settings, and in particular our patient here. So I just took our PEEP and then increased it a little bit that first day, maintained the FiO2 just because we were already at that 60%, and then bumped it up even more just so we can maintain. And that's just kind of showing that instability that he's experiencing. And it could be for a number of reasons, like I said, could be something like atelectasis, or could even be worsening of the ARDS he's experiencing. And then next, I kind of wanted to divulge into what might happen if, say, he did have these ventilator-associated events, was worsening, and then eventually failed conventional ventilation. So I decided, say he did fail conventional ventilation, I decided just to do the high flow oscillatory ventilation, just because some of the studies I was looking into did show more favorability towards these PRDS patients, and especially just for lung recruitment, and especially saying that he wasn't able to maintain um, adequate settings on these low volumes and high settings for PEEP. So this would just be another way to help optimize the oxygenation and ventilation. And so for the settings, I just did, basic settings that would fit towards him. Amplitude, just adjust for that wiggle. The hertz, I did see more favorable for the 8 to 10 range starting out, considering his weight. And then I time just 33%. That was standard. And then the MAP, I did see some differing, but from our own readings, I did see the 3 to 5 above what he was on the conventional ventilation. And then I also did maintain that 60% FiO2, which obviously we can change depending on his settings. But this is kind of what we just wanted to take that next step further for this patient, especially if he did have those events and then failed conventional ventilation.
The early mobility of this patient would be definitely ideal. I think that, and this can be done through passive mobilization, positioning, and discussion of mobilization in general. I'm sure we've all seen this in the ICU. I've seen it with adults many times. We get that person up and moving. This can help wean sedation as well, and just kind of get them to kind of like move those lungs around, move their body around, because it does have a huge beneficial impact on their recovery. And one of the studies I found, which I found super interesting, was that sepsis, hyperglycemia, prolonged hospital stay, and the use of corticosteroids can be related to reduced muscle strength and skin integrity. And I did reference that, which I thought that, especially the corticosteroids part, I thought that was pretty crazy. And kind of a small definition of what early mobility really is early mobilization is defined as a mobility exercise. I'm going to bring up passive mobilization again, or active at the earliest point in time is definitely beneficial for this patient. And especially with this patient, I've seen patients be mobilized day of being intubated if we want to get them extubated as soon as possible. And that is due, I think it's mainly due to getting that sedation off, and it really has a big impact on that. Kind of going into this, which this could have an effect on early mobility, but ICU delirium. So this patient has a score of -2, and a PCAM ICU score of -2 indicates that they are lightly sedated, which I think could really contribute to the early mobilization. I think that if we get that going, then this patient would be heavily benefited from this. And the patient responds to eyes, opens eyes to voice, and maintains eye contact for less than 10 seconds. That's kind of the what -2 on the PCAM ICU score looks like. So the patient can respond, open eyes to voice, but it is less than 10 seconds. And kind of like I said earlier, early mobility is a start to help wear off this sedation. And sedation can definitely cause delirium. And kind of the PCAM ICU is kind of introduced into the pediatric ICU, and it's been used commonly, and I saw it used at Vanderbilt Medical Center. And you kind of just diagnose delirium in pediatric patients like this case. But yeah, -2, just lightly sedated, and I think early mobility will definitely benefit this patient. Going into the nutrition, this patient needs to be receiving fluids, electrolytes for hydration, and they do have a high metabolic demand. So proteins, carbohydrates, lipids, they're all very crucial. And I kind of, in one of the studies I read, I think I'm going to pronounce this right, enteral nutrition. So it's just the basic tube feeding, in which the patients that aren't able to meet their intake demands by themselves, so that when you're intubated, you can't eat. So I think enteral nutrition, in which we see a lot in the ICU, would be most beneficial for this patient. And here are references